This section is dedicated to the use of ultrasonography on trauma. The history of the use of ultrasound in trauma is began in 1970 with these papers, the ultrasonic scanning and the diagnosis of splenic hematoma, and the echographic evaluation of splenic injury after blunt trauma. In these papers, we have a sensitivity in highlighting the splenic damage of 18%. They will spend at least 15 years before finding a new publication about the use of ultrasound in trauma. In fact, in 1919, we have the ultrasound in blunt abdominal trauma, where were evaluated a high number of patients, 818, about the ability to highlight intra-abdominal fluid with sensitivity of 89% and a great specificity, 100%, with an accuracy of 98%. During all these years and until the mid-19th century, there was a little interest towards ultrasonography in emergency, particularly in the trauma. While there were guidelines for a diagnostic peritoneal lavage. Do you know the diagnostic peritoneal lavage? What is? Diagnostic peritoneal lavage is a technique in which we insert into the abdomen, into the peritoneum, with a catheter. We insert in the peritoneum 1 to 2 liters of normal saline solution, and then we pull out this and we analyze. If we find blood, probably we are in hemoperitoneum. This is an old technique, but in these years are more used. So in 1988, there is this paper about ultrasound in abdominal trauma as an alternative to peritoneal lavage. In 1993, there is this important paper that are about the prospective comparison of diagnostic peritoneal lavage with CT scan and the peritoneal lavage and ultrasound. And this is the sensitivity, the specificity, and the accuracy of the three methods. In 1996 was produced the fixed definition of FAST, focused abdominal sonography for trauma with this indication: hemodynamically unstable blunt abdominal trauma, and the objectives are the search for only peritoneal effusion as an alternative to diagnostic peritoneal lavage. Diagnostic peritoneal lavage is bounded by complication. The important complication get from 1 to 5% of cases. In the year 1997 was produced the second definition of FAST, and as you can see, focused not abdominal but assessment with sonography for trauma. Why? Because the indications are hemodynamically unstable, blunt thoraco-abdominal trauma. In fact, the object is to search for pleura, pericardial, and peritoneal effusion. Finally, in 1999, the first guidelines are published, and as a result for an international consensus conference, I published in the Journal of Trauma. What are the objectives of the trauma sonography? First of all, to determine the region of a cardiac respiratory arrest and the chance of recovering, and to determine the region of the shock. Is there an hemoperitoneum? Is there an hemothorax? Is there a pericardial tamponade? Or is there a pneumothorax, a tension pneumothorax? Which are the advantages of the abdominal trauma ultrasonography? It's quick, 30 seconds to 5 minutes about the scientific literature. Quick initial screening, it can be easy and repeated. You can repeat the exam after 1 minute, 10 minutes. The exam is easy to perform, and only a small percentage of the exam is uncertain. What is the disadvantages? It's not defined lesion. It does not highlight the solid organ injuries or the one located in the retroperitoneum, diaphragm, on the hollow viscera. Is not useful to identify the source of bleeding or to classify the specific injuries. And it does not detect a small amount of blood, less than 250 milliliters. Where does the fluid accumulate? As you can see, the fluid accumulates in the pleural, subphrenic, perinephric, subhepatic, and pelvis area. This is a patient that lie down when arrived the patient with the trauma. This is the position of the patient. So, the focus assessment sonography for trauma have these 4 scans that are the right upper quadrant, where we can find the Morrison pouch, the left upper quadrant with the Splenorenal Space, the Suprapubic with the Douglas patch, and the Subxiphoid region, and you see the pericardium. This is the right upper quadrant scan, and where to put the probe. The probe is into the low right intercostal space at level of 89th internal space, between the mid-axillary to posterior axillary line. You can view of the right kidney and the retroperitoneal space. This is the most common site to displace hemoperitoneum. And this is technically easiest to view. This is a CT scan. This is the Morrison patch. This is an ultrasonography, anterior, posterior, upper and lower. This is the liver. This is the kidney, and this is the Morrison patch. Liver, kidney, and the Morrison patch. This is a normal Morrison patch. This is a thin strip of blood. This is a lot of fluid. Lot of fluid or blood in trauma. We suspect that this is blood. This is the liver, this is the kidney, and this is the fluid, okay? This is the fluid in the Morrison patch. This is the liver and this is the kidney. Okay, this is the left upper quadrant with the splenorenal space. where to put the probe, and we must put the probe into the left intercostal space about the 6 to 19 intercostal space, mid-axillary to posterior axillary line. Is upper than the Morrison patch and more posterior. The goal is to display the virtual hyperechoic space between the spleen and kidney on the left. So this is a splenorenal space in the CT scan. This anterior, posterior, upper and lower is the same of the Morrison patch, the images. This is the spleen, this is the kidney, and this is the splenorenal space. Not fluid, spleen, kidney, not fluid. This is a hyperechoic line. This is fluid around the spleen, okay? The suprapubic scan or pelvic window, where to put the probe. We can put the probe 2-3 centimeters above the pubic symphysis, positioned in the both or in transverse or in longitudinal scan. We can find the Douglas patch, that is or recto-uterine space or recto-vesical space, where abdominal fluid flowing from the side collect. Is preferably have a full bladder for the acoustic window, so it's advisable to feed the catheter with the introduction at least of 300–305 milliliter or normal saline solution. This is a suprapubic projection with the pelvic window. This is transverse and longitudinal projection. So, in female, the transverse scan is this, and you can see this is normal, the bladder, the uterus. This is a thin layer of free fluid, as you can see in this point, and this is massive effusion after the uterus. This is a longitudinal scan in female. This is normal. This is a thin layer, and this is a massive effusion around the uterus. In male, this is a transversal scan. This is the bladder. This is prostate. Normal. This is a thin layer of free fluid. This is the longitudinal scan. This is normal. This is a massive effusion in retrovesical pouch. So, which is the sensitivity or specificity of the ultrasonography in abdominal trauma? As you can see, the specificity is very high, 95% to 100%, to show only intraperitoneal fluid, Which are the limits for abdominal trauma ultrasonography? Low sensitivity for solid organ injury, hollow viscera injury, and isolated lesion of the bowel and the mesentery. Indeed, up to 34% of patients with intraperitoneal injury will not have hemoperitoneum to ultrasound examination. In fact, neglected injuries are spleen, liver, kidney, mesentery, pancreas. 70% without hemoperitoneum needs surgery or angiography. So, negative ultrasound doesn't rule out a surgical or angiographically correctable lesion. The sensitivity is influenced by the blood volume, the number of projection or scan made, the previous abdominal surgery for adherence, the time from the injury, but we say that we can repeat the exam, so it's not important, this problem. The speed of bleeding, that is correlated to the time from the injury, the level of experience, and the equipment. This is the sensitivity of various scans. 51% of Morrison, 58% of Splenorenal. The major sensitivity is for Douglas, but the most important is that multiple scans have a sensitivity up to 87% and a specificity of 100%. So, if there is time, perform all projection, all scan. This is a sensitivity that increases with the increase of the amount of fluid. So, especially, in particular, from 200 milliliters onwards. From 200 milliliters onwards, the sensitivity is very high. The differential diagnosis, we have a false positive and false negative. So, the false positive are perinephric fat, ascites, urine from bladder rupture, and bile for gallbladder rupture, but is not a very important problem because a patient with a bladder rupture or gallbladder rupture needs surgery, the same with hemoperitoneum, so it's not very important. Intestine filled with fluid between the liver and the kidney. Sometimes it's possible to have this position. False negative, adhesion for previous surgery, as we said, and minimal bleeding, but you can repeat the exam, and so this is not important. This is an example of perinephric fat. This perinephric fat is like a filled fluid, but have an homogeneous echo. Is not black. It's not black like a blood, This is a subxiphoid projection, and this is an example of cardiac tamponade, as we see yesterday. Another important utility of ultrasonography is for echo-guided pericardiocentesis. Okay? So, why extended the fast not only for abdominal fast but for the chest? Because the anatomical lines between thorax and abdomen are rarely respected by the kinetic energy of the trauma. This is a patient, but we don't understand where is the head, the chest, the abdomen. So, in 2004, we have the third definition of FAST, or extended FAST, extended focused assessment with sonography for trauma. The indications are hemodynamic unstable blunt abdominal and thoracic trauma, but the objectives are pleural pericardia and peritoneal effusion as the FAST, more pneumothorax. Finally, the extended FAST was included in 2008 in Class 1 evidence in the emergency ultrasound guideline of the American College of Emergency Physicians. which are the indication of chest ultrasonography in trauma? Hemopericardium, hemothorax, pneumothorax, and the complication of the trauma in intensive care unit, the pulmonary contusion and their complication are very important. Acute lung injury, acute distress respiratory syndrome, sepsis, and the evaluation of the rib and sternal fracture. This is CT scan. This is an hemothorax. This is the liver. This hyperechoic line is diaphragm, and this is fluid. In trauma, probably is hemothorax. Okay. As you can see in this clip, this is the hemothorax. This is a corpusculated diffusion. Okay. So we know the story of the patient that have an incident, a trauma. So is important. But if you see a pleural effusion like this, probably this is blood. This is the diaphragm. This is a parenchymatous organ. I think that is the liver, and this is a hemothorax. This is the sensitivity and the specificity of the ultrasound intensity ray to reveal hemothorax. But the most important is that ultrasonography is faster. 1 minute versus 14 minutes. We can evaluate also an extrapleural hematoma. Repeat, this is the subcutaneous fat, okay? This is ribs. This is intercostal muscle. This is the pleural line. This is fluid. That is extrapleural fluid, okay? This patient have a chest trauma, so this is, in this point, there is a fluid, a blood fluid for extrapleural hematoma. We can evaluate also the sternal fracture. This is a longitudinal scan of the sternal. So you can see the interruption, the cortical of the bone. When you evaluate a bone, you can see only a hyperechoic line because the ultrasound reflect. So this is the cortical of the sternal fracture. This is the interruption of the cortical, okay? The rib fracture, by a transversal scan, okay, the probe is parallel to the rib. With the longitudinal scan, you can see the images that you know well of the rib. This is the cortical of the rib, and this is the interruption of the cortical. In this point, there is a fracture. This is a rib fracture. Okay, and now talk about the pneumothorax. The pneumothorax occurs when air enters between the parietal and visceral pleura. So the lung is not possible to expand, okay? There is no pleural gliding. we said yesterday that when air enters between the visceral and parietal pleura, there is no pleural gliding. We can see the E line, okay, but not the B line, because the visceral and parietal pleura are not gliding, not sliding. So it's impossible to see the B line. The B line are generated only if there is a sliding or gliding of the pleura. So, first of all, one, no sliding. Visceral pleura does not slide on parietal pleura. How does it show in the ultrasound? This is a gliding or sliding B mode. It's a normal lung, okay? You can see very well the gliding of the pleura. This is a PNXP mode. This is immobile pleura, okay? It's clear. The utility of M mode, the usefulness of M mode. Sliding M mode of a normal gliding, you can see, as said yesterday, the seashore line, okay? These are B-line that are cut by the M mode. So you can see the seashore line and the B-line. And this is a M mode pneumothorax. As you can see, is the same of the C. Okay? So, the absence of sliding is a condition strongly suggests pneumothorax, but it is not certain. In fact, pleurodesis, severe acute respiratory distress syndrome, atelectasis, or main-stem broncho intubation, protective ventilation with IPEP can bring lack of sliding. For example, if you make an intubation of the patient and you put the tube only in the bronchus, the other lung are not ventilation. So you not find the gliding or sliding. This is used for the control of intubation. You don't with the stethoscope, but you put the probe, you don't see the gliding, so you can try the tube in trachea. Second, no B-line. You know that B-line original from the visceral pleura, their detection indicate the visceral pleura addressed to parietal pleura. So in pneumothorax, there are no B-line. So the third feature of pneumothorax is the presence of lung point. Lung point is a point located on the chest wall where the shape of the lung replaces the outline of pneumothorax. This is a sensitivity of 66%, but important, this is a specificity of 100%. If you find the lung point, you are sure that there is a pneumothorax. So, this is an example of lung point. You can see the pleura that gliding, okay? On the right side, there are no gliding. Clear? Okay? This is the lung point. This is a zoom of the the same images. Okay, there is no gliding, and this is an M mode. There is beline. In this point, a beline, no beline on the right side. Okay. Finally, the absence of lung pulse. What is lung pulse? A lung pulse is a rhythmic movement with the visceral pleural pulse and parietal pleura. This is the lung pulse. In pneumothorax, we have the absence of lung pulse. So, to resume, the flow chart of pneumothorax diagnosis. Search for sliding. First of all, search for sliding. If there is sliding, there is no pneumothorax. If there is no sliding, search for beline. There is beline, no pneumothorax. Search for beline. No beline, search for lung point. There is lung point? Yes, there is a pneumothorax. There is no lung point, search for lung pulse. If there is lung pulse, no pneumothorax. If no lung pulse, there is a pneumothorax. Okay? This is the flow chart. So, key point. The sliding is absent. The E-line detected. There is beline. There are no E-line. There are no beline. There is a lung point. There is no lung pulse. The medicine is not exactly science, so the only exception for lack of lung point is if we have a PNX, pneumothorax of all the lung. So you don't find the lung point because all the pleura is involved. Okay? The pulmonary contusion. The pulmonary contusion is very important because they have an high mortality from 10 to 25%. In spite of these incidents, it is difficult to diagnose in emergency department only with chest X-ray. The gold standard is chest CT, but not all the patients can make the chest CT. So, the features of pulmonary contusion are the alveolar interstitial syndrome, as defined as an unilateral or bilateral beline starting from pleural line with patient where acute cardiogenic pulmonary edema is not suspected because it's similar to the pulmonary edema. The detection of peripheral parenchymal lesion with C-line starting for hyperechoic subpleural focal images, like this is like the pulmonary consolidation, okay? Confluent consolidation, or sometimes a parenchymal rupture with localized pleural effusion. So we can see some example. This is a pleural microareolar pattern. This is a contusion at the CT scan. And as you can see, the beline arises from the pleural line, the C-line arises from the contusion. Okay? This is a pulmonary contusion, subpleural pulmonary contusion. This is another contusion. This is the C line that arises from the contusion. Why? So, why extended fast? What do you think about this chest X-ray? You are not a medical doctor or radiologist, but it's normal. Seems to be normal. So, this is the contusion. This is, in Italian, rupture, parenchymal rupture. Okay? So, this is the standard fax examination technique. To scan of the chest, left parasternal, right parasternal, only anterior, where you can find the pneumothorax. The massive tension pneumothorax to evaluation maxi pleural pneumothorax, you can use only this scan. Okay. This is a pericardial scan. This is the Morrison, but by this position you can see the pleural effusion on the right lung and the pleural effusion of the left lung. So, left pleural, perisplenic, left paracolic, right pleural, perihepatic, right paracolic, and this is the pelvic scan. So, the fast, more to scan of the chest, extended fast. So, an extended fast exam that includes also chest examination and supplemental diagnostic value in trauma, while adding only a few more minutes to abdominal examination. It allows to accurately diagnosis of hemothorax, hemopericardium, pneumothorax, and probably all of the initial phase of lung contusion. It's not important in emergency to see the lung contusion. Is important in the second phase when you are the patient in intensive care unit, but probably of the initial phase of lung contusion you can see. It requires more complex training and thoracic ultrasound semiotic knowledge that you see is not very difficult, the semiotic of ultrasonography of chest. Fast hemothorax and pneumothorax sensitivity, and probably also for pulmonary contusion is much higher than X-ray. This is what the scientific literature said us.